Your Highness, good morning. Good morning, everyone. Prime Minister, I think you're here. Your Royal Highnesses, Your Excellencies, Ministers, distinguished guests, ladies and gentlemen. It's good to see everyone after what I'm sure has been a very enjoyable evening here in large numbers and wonderfully on time. This, as you very well know, is the second day of Wish 2015. And this morning we're going to hear, first of all, from our third keynote speaker. And then there's going to be a session on the global diffusion of health innovation and the leading health systems network. Now, it's my pleasure to interview, it'd be equal pleasure to interview, but I'm going to introduce our next speaker, who's a fascinating and important figure. He entered the world stage as Mother Teresa's cardiac surgeon, Dr. Devi Shetty. He's become recognized as a true innovator. The Wall Street Journal crowned him as the Henry Ford of cardiac surgery. Narayana's health visionary approach to healthcare is surprisingly simple, using economies of scale to drive down costs. Narayana surgeons perform twice as many procedures as the Cleveland Clinic, but at a fraction of the cost. Think of the implications of that. His amazing work proves that it's possible to provide quality care for millions without breaking budgets. So would you please welcome to the stage Dr. Devi Shetty.
Your Highness, I'm extremely grateful to the organizers for giving me the opportunity to be with you all this morning. Can I have the first slide, please? Yeah. I am a cardiac surgeon by profession, but I have a very interesting job. My job is putting price tag on human life. Now, you must be wondering what kind of job it is. Every day, I see about 60 to 100 heart patients in my office. Half of them are children, small babies. A typical patient of mine is a little baby on the mother's lap. I examine the child and I tell the mother that your baby has a hole in the heart and he needs an open heart surgery. She looks at my eyes and she has only one question. You know what that question is? How much it is going to cost? And I tell her that it is going to cost $1,000, which she doesn't have. And that is a price tag on the child's life. If she comes up with $1,000, I can do the operation, she can have the child. If she doesn't have $1,000, she's going to lose the child. And this is the price tag on human life. This is what I do from morning till evening. This is what all the surgeons in my country do every day. This is what all the surgeons in Asia, Africa, Latin America, all we do is putting price tag on human life. Why? Because we never change the way the healthcare is delivered in the last 100 years. How long you are going to tolerate? How long millions of people are going to die because there is a solution, it is not available. It is not affordable. If a solution is not affordable, it is not a solution. I started my journey from Guy's Hospital in London as a young cardiac surgeon. And in 25 years, we walked long distance trying to help people. My country requires 2 million heart surgeries a year. And all of us in the country put together perform 120,000 heart surgeries. What happens to the rest? They perish gradually over a period of time. Are they old, retired people? No. They are the young breadwinners of the family. In the process, we perhaps produce one of the largest number of young widows in the world. How long are we going to tolerate? So we thought, let's address this. So we built a health city in Bangalore called Narayana Health City. You can see the building. Our intention is to have 5,000 beds in one complex. And the first building is a heart hospital where I operate, has the infrastructure to perform 60 heart surgeries in a day. Currently, we do about 27 to 35 heart surgeries a day. We have 29 hospitals across the country. 12% of the heart surgery done in India is done by us. And our target is to do a major heart operation for $800. We are nowhere close to it, but soon we will reach there. And for you to reassure about the quality, our hospital is accredited by Joint Commission of US. We may build a hospital, but people do not have the money to pay for it. So 11 years ago, we convinced our government of Karnataka to launch a health insurance with a premium of 11 cents per month. Why 11 cents? 11 cents is the price of one packet of cigarette the farmers smoke every day. We convinced them to stop smoking one day, pay for the health care. In the first year, we had 1.7 million farmers paying 11 cents per month. And in the last 10 years, we have grown, and now we have 4 million farmers contributing 22 cents per month. And in 10 years period, 710,000 various surgeries are done, and 85,000 farmers had a heart operation in one of the 400 network hospitals across the state. This is the power of a country with 1.2 billion population. Poor people in isolation are weak, but together they are very strong. Now, one of the interesting things about health insurance, in the last 10 years, whenever you come up with a health insurance for poor people of this type, there is a lot of fraud. People do take advantage of the system. But in this insurance, last 10 years, there hasn't been a single fraud, because this insurance scheme is only for the operation, and nobody wants to have an operation even if it is free. Now we are trying to convince our government. We have 850 million mobile phone subscribers who are spending about 150 rupees per month just to speak on the mobile phone. If we can collect 20 rupees from each mobile phone subscriber, we can cover the healthcare cost of 850 million people. This is the beauty of technology, which brings millions of people together. When all this transformation happens, we believe that within the next 10 years, India will become the first country in the world to dissociate healthcare from affluence. India will prove to the world that the wealth of the nation has nothing to do with the quality of healthcare its citizens can enjoy. But for all this to happen, we need to put the building blocks. We need hospital beds. We have 100 towns in India with a population of 500,000 to 1 million where there is no heart hospital. They can't afford a heart hospital because they are very expensive. So 2 years ago, we worked with India's largest construction company called L&T, and we told them that we need to build a 300-bed super specialty heart hospital where heart surgery can be done, heart transplant can be done, kidney transplant, organ transplant, joint replacement, everything can be done. But we can only spend $6 million for the building and the equipments. And it takes about 2 years to build such hospital. We wanted to build a hospital in 6 months. It was a challenge because a hospital of this size in the United States would cost about $600 million. We wanted to do it for $6 million. And the construction company took the challenge, and you can see the building. The top is the artist's impression, and the bottom picture shows the hospital, which is functional. And this hospital has done over 200 heart operations, and it is doing extremely, extremely well. In this hospital, there is no central air conditioning. We live in tropical countries where I live in a house which is not centrally air conditioned. Why should a hospital be centrally air conditioned? Only the operating room and ICUs are centrally air conditioned. Central air conditioning doesn't prevent infection. Central air conditioning is the commonest source of infection. Essentially, we believe in the past, and we always think that the future is an extension of the past. Future is different. It is up to you how you want to create the future. There are a lot of innovations one can do without really spending money. My son is a graduate from Stanford University, and his students, the batchmates and the juniors, they keep asking us for various projects for their MBA program. So one of the team, when they arrived from Stanford, we gave them a very interesting project called Care Companion Program. This involves involving and training the patient's spouse to take care of the patient after a heart operation. All over the world, patient spouse is not involved in the patient care when the patient is in the hospital. Traditionally, a man gets admitted, he gets a heart operation done, his wife stays with the patient. She is not allowed to touch the patient. 4 days after the heart surgery, we call the wife, we give her one plastic bag with all the medicines and tell her that she has to take care of the husband. She's lost. She doesn't know what to do with those medicines. Instead, we developed 1-minute films on audio visuals, which can be downloaded from the YouTube on their mobile phone. How to do the wound dressing, how to check the pulse rate, how to check the blood pressure with the digital manometer, how to give physiotherapy. These are the basic things we have taught. And it is in the form of a training program which will extend 4 hours. And when this was launched 2 years ago, patient's family embraced it, and the overall outcome and the readmission rate came down drastically because there was someone at home taking care of the patient, and if there is a problem, she knew exactly when to call the doctor and what to do. And interestingly, this program was recognized by the British Parliamentary Commission Committee that one of the best patient empowerment tool. And how much it costed us? It costed us nothing. Another interesting program is about preventing the bed sore or pressure ulcer following heart operation. The incidence of bed sore following a heart operation across the world is 4% to 40%. It is extremely, extremely high. And our nurses and surgeons decided that we should eliminate this complication because bed sore is very painful. and it is a very expensive complication. So they developed a system of monitoring the pressure point from the point of admission to the point of discharge, constantly recording with the mobile phone apps about which is the pressure sore area, what are the changes, and they made accountability at every level. In the process, last 2 years, we have virtually eliminated the bed sore from our hospital. Believe me, we are a hospital doing 600 to 700 heart surgeries a month. So we have virtually managed to eliminate. And the recognition for this protocol is that their procedure was accepted by American Nursing Association as one of the best practices to prevent bed sore following any operation. Again, how much it costed us? It costed us nothing. When you have lots of money in the bank, your brain stops working. 4 years ago, we decided across India, all over the developed world, developing countries, when a heart surgery or a complex operation is done, they use linen gowns because disposable gowns are very expensive. With the high incidence of viral infections going around the world, it is not safe. You can't wash a blood-drenched linen after a heart operation. So we decided to go for disposable gowns and drapes. And there were 2 multinational companies which were making them, and they wanted us to pay them $100 for each heart operation. When our target to do the heart operation for $800, we couldn't spend $100 for disposable gowns and drapes. So we got hold of young MBAs who have graduated from the various business schools, and we asked them to create a company. We asked them to make the disposable gowns and drapes because material for disposable gowns are made by a company called Alstom. All it required is cutting and stitching. In Bangalore, we have thousands of young ladies who can cut and stitch the most beautiful suits. And for them, stitching the surgical gown is nothing. And this is how a company called Ameralis was born. And we promised them 12% of the Indian market if they can come up with a product, because that's our group does 12% of the heart surgery done in India is done by us. So we offered them the business. And they came up with a product. And today, we are buying disposable gowns and drapes from them for $12. From $5,000, we got a better product for $12. And this company now has a CE marking. Soon they will be exporting. They believe that the cost can come down to $5. So it is cheaper than linen, what most hospitals are using. I just want to talk to you the next couple of minutes about the next big thing in healthcare. Next big thing in healthcare is not going to be a magic pill, a fastest scanner, or a new operation. It is going to be the information technology. We invested heavily on IT, and we have Oracle ERP on a cloud. We have hospitals in 29 locations. By 12 o'clock in the afternoon, senior administrators, senior doctors get a SMS on their mobile phone with the previous day's revenue, previous day's expenses, and the EBITDA margin. For us, looking at the profit and loss account of a hospital at the end of the month is like reading a postmortem report. You can't do anything about it. Whereas looking at the profit and loss account on a daily basis is a diagnostic tool, and you can take necessary action. Next question is, Why do you want to let the doctors know about the cost of doing things or the balance sheet? It is very, very important for the doctors to know how much it costs for a procedure. Do you know why? I just want to ask you all, which is the most expensive medical equipment? Can anybody guess which is the most expensive medical equipment? The most expensive medical equipment is a doctor's pen. Doctors prescribe all kinds of investigations, all kinds of tests, prescribe all kinds of medicines without really knowing how much it costs, but fully knowing that it doesn't work. So unless the doctors are educated to understand the cost implications of every action, healthcare will not change. So this is the idea of data. We believe in God, but for everything else, we need the data. How we use information technology, I just want you to concentrate on this slide. There are millions of people in this world taking a medicine called warfarin or acetron, which is nothing but rat poison, for preventing the blood clot. We have thousands of patients who have an artificial valve. They are on this rat poison medicine. But when you take this medicine, every 6 weeks, you need to check the blood for a level called INR and titrate the dose. Because if you do not take the right dose, the valve will get blocked or patient will bleed. But our patients are not educated. So 6 months after the operation, they feel well. They don't bother doing the test or taking the right dose. This particular person who's on the phone is a patient of ours who had a valve replacement done. And this patient was managing his INR extremely well. He was not a doctor. And he was a paraplegic at home. And he had no job. So he wanted us to give him a job. So we taught him how to manage INR following operation. And Stanford University developed an algorithm to help him to give the right dose. So he has a mobile phone in his house, and he has internet connection. Every day, he gets 300 to 500 calls or text messages from few thousand patients across the country and across the world today, and asking him about the right dose. And he prescribes the right dose, and there is hardly any complication. And it is done entirely free. And how much it costs? It hardly costs us few $100s a month. That's all it costs. This is the power of technology, and this is a glimpse of the future when patients will access high-tech healthcare from their own home. The next big problem, or the next big thing, what is going to happen in healthcare is going to be online clinics. We believe that within the next 10 years, entire outpatient services offered by the doctors will disappear. Patient will stay at home and he will have online consultation. So this is a young doctor. She's a diabetologist called Poonam. She's sitting at home and she's fiddling around with her mobile phone. She's not playing with the child. Poonam is giving an on-site online consultation for diabetes using WhatsApp. Poonam is taking care of hundreds of diabetic patients across India, sitting at home, because majority of the young ladies in our country who are doctors, when they have little children, they don't want to go for work. They want to be with the children. Now, she is a brilliant diabetologist. Diabetologists need not touch the patient. So we have connected Poonam with thousands of patients, and she's taking care of the diabetic problem of all these patients. Like Poonam, There are thousands of women in India who are who are endocrinologists, who are dermatologists, who are radiologists, who do not want to work in the hospital because they want to take care of the children. Today, we are in a position to bring them to the real world of healthcare, which is boundaryless. Today, Poonam can take care of a diabetic patient in India or Africa or elsewhere. And the next big thing in healthcare is going to be the slide here. Our group is working on replacing all the paper charts with iPads. We believe that in the future, within the next 1 or 2 years, every hospital, when they admit a patient, they will not have a chart. They will have an iPad, and the doctors will be able to get all the information through their mobile phones. And this is going to be the next big thing in healthcare, which will dramatically reduce the risk of a hospital, the doctors and the hospital making mistakes, so-called medical error. Medical error is one of the biggest problems in healthcare. If 200 patients get admitted to American hospital, which is perhaps some of the safest hospitals in the world, if 200 patients get admitted, 1 in 200 dies due to medical error, just by spending one night in American hospital. It is not medical negligence. Getting admitted to an American hospital is 10 times riskier than skydiving. You can imagine how safe it is in other country hospitals. But all these complications can be addressed if you follow the process and protocol. And that can be built in a country like ours, which is blessed with millions of fantastic software engineers at a fraction of the cost. Now, I have another 6 minutes, and the main purpose of me coming here is not to talk about what I have already spoken to you. I have come here to talk to you about what we can do collectively to change the way healthcare is delivered. What is desperately required for this world today is a global university for medical, nursing, and paramedical education. Now, why global university? Because we need a global university because WHO estimates that there is a shortage of 12.9 million healthcare workers today. And my estimate is that it is going to be twice as that much because my own country, India, requires 3 million new doctors. We need 6 million nurses. Today, India requires 500 new medical colleges. We have the largest number of medical colleges in the world. We have 450 medical colleges. If we add 100 new medical colleges a year in India for the next 5 years, by year 2025, we will have adequate number of doctors. That can't go on, simply because in India, to start a medical school, it costs $50 million, which is a large amount of money. We need to change the way medical colleges are built. How do we change it? It is possible. And why do we need to change it? We need to change it because cost of medical education has to come down significantly. Why? Because children from poor families should get into medical college and they should become doctors. Outstanding doctors across the world who change the way healthcare is delivered, who have magic in their finger, who have passion to change things, generally come from deprived background. Because these are the children who have the fire in the belly, who will work for 18 to 20 hours a day and change the way healthcare is delivered. But with the $50 million medical college, these children cannot join these medical colleges. If we can create how our forefathers create United Nations, if all the countries, I'm not talking about the US and Europe, they can help themselves. I'm talking about Asia, Africa, and Latin America. If all these countries come together, create a virtual global university, identify the best academicians who write the curriculum. 80% of the curriculum is local, 80% is standard, 20% is local. And the curriculum, syllabus, everything is available online. And we identify hospitals across this part of the world with 300 beds as medical schools. And most of the theory part of it is online, and the rest of the thing, the medical faculty of the hospital will educate. And there is, every year, virtual university, global university will conduct an eligibility exam like GMAT conducting exam in 150 countries. We can create those online eligibility tests. At the end of 5 years, when they graduate, global university offers them the degree, and then these doctors can work in any country of their choice. There are countries in Asia. In the whole country, there is one pediatric surgeon, and they give birth to thousands of babies. We have a large number of pediatric surgeons who are willing to go to those countries, but those countries do not recognize our degree. So we need to create a global university for medical, paramedical, and nursing education. If we do not do this, today when we are talking about healthcare, we are talking about money. We are saying Africa has poor healthcare because they have no money. At some point of time, money will come, but people will not be there. We have to dramatically change how the doctors are trained. 120 years ago, when Flexner came up with the concept of medical education, which dramatically changed the way the medical education was offered, those days it was required because they were picking up farm boys and giving them a 6-month course in medicine and called them as doctors. So Flexner said, quality is poor. We need to extend the training program. Now we have gone to the other extreme. Is it really required for a doctor to spend 14 years to learn hand surgery? It is not required. I have seen nurses doing a fantastic hand operation in the side room of a Malaysian hospital. They're not doctors. They do amazing work. There are lady surgeons in Africa doing complex operation to treat vesicovaginal fistula. They're not doctors. Time has come for us to introspect and create a university which has no boundaries, which will take away the pain and suffering of this world. I'm extremely grateful to all of you for giving me this opportunity. Thank you.